Hi, everybody. So, one of my requirements as head of department, semi-head of department, is to do these clinical audits. And for those of you who've been with us for a long time, you know that from time to time we do these audits and we present them to you guys as well. So, this month I actually did an audit on our management of urinary retention. So we're just going to go through it. There's a few things to learn from here, but the main things are actually going to be included in some videos that I found, and I'm going to include after this. And I would suggest watching them when you have a chance. There's a very good lecture from UCLA. There's some 2 or 3 good refreshers on catheter insertion and suprapubic catheter insertion. So I would suggest you guys also watch that, especially if you haven't had a chance to do it. So this is about urinary retention. It's something that we're faced with all the time. So these are just our statistics. So what we did was we basically took these 7 criteria and I took it against 8 patients and we tried to see how the department did. And overall, the department didn't do too badly. We were successful more than 70% of the time. So the main things that we had to check was this an index presentation? Is patient known with obstruction? Did we manage to get a Foley's in? Did we note if there was bradycardia, fullness of the bladder? Did the patient require dilation, suprapubic? And even though it's not a comprehensive, assessment of of urinary retention and of urethral strictures, it covers what we can manage in a semi-rural hospital. So that's why I've picked these, all right? So just so that you know, now I'm not going to read through this line by line. Basically, what we're going to do is that we're going to talk about why we need to look at these things, all right? So the first things that we need to know are, is this an index presentation? So is this the first time that the patient is presenting with urinary retention? Now, there's a few things that we need to consider what you call it, when the patient presents for the first time. And the first and most important thing is age, because there's a big difference between a young person presenting and an elderly person presenting. It doesn't matter male or female, even though in this audit that I did, all the patients happen to be male, but it's not that females can't present with it. So if you have a younger person presenting, there's two most likely causes, infection and trauma. And trauma, there's 2 types, it's blunt and penetrating. So those are the most common things. And infections, of course, we're talking about sexually transmitted infections, all right? STIs, which also stands for soft tissue injuries in a lot of them. So it often gets quite confusing. We're trying to go through. We had a lot of patients where the diagnosis on the top STI. So we took it and we had to look and say, oh, it's soft tissue injuries. Okay. But in any case, so it is a sexually transmitted. The most common in ours is gonorrhea. Then you do get things like any of the diseases that cause urethral discharge, basically. So that's the main thing that you've got to look at, and anything that may cause cystitis, because then it may affect the bladder neck as well. So any of those can lead to a problem where the patient doesn't have the ability to pass urine. Now, the good part is with infections, especially if it's a first presentation, the likelihood is that your patient is going to get relief with the urinary catheter. Patient needs lifestyle modification, encouragement to use condoms, barrier methods of contraception to prevent transmission. And generally, they'll do well after an acute bout, and it's a very painful thing. So a lot of people don't want to go through it again, be it either the catheterization or the STI itself. And then, of course, if it's blunt or penetrating trauma, that is quite different because you can get complete transection of the urethra, swelling around the urethra. There's quite a few things that can happen. So we did have a patient recently who was injured. Prisoner was actually kicked in the scrota and immediately couldn't pass urine. And it was quite an interesting case because he went in, the catheter passed, and even after the catheter passed, he was still having difficulty. And the reason being the swelling around the urethra coming from the scrotum upwards was so severe that it had actually managed to compress the Foley's catheter. So that was quite an interesting one. And I found it quite amazing that something like that happened. Our urology department did get involved. Patient ended up in Grace and actually having suprapubic inserted, and eventually I think he's ended up now with ureteric stents as well, because the damage was so severe to the bladder neck, and that which wasn't picked up initially, but it was difficult to pick up initially. They only picked it up on CT. So, and of course, in an elderly gentleman, why any of these may also be the cause. So chronic infections, chronic trauma, and of course, I mean, we don't know, somebody was, for example, they used to find this a lot in people who used to ride horses, they used to have chronic blunt trauma, and then they would eventually develop these problems. And in America, I know it's a running joke that, you're an old cowboy when you have a Foley's catheter inserted. So and it's a joke amongst the urologists on that side as well. So they see somebody coming in with a cowboy hat, they know that they need to insert a catheter immediately. But in the elderly gentleman, the more common cause is, of course, the prostate, and of course, it's prostate enlargement, be it benign or be it malignant. So that's an important thing to actually check out. Now, in our case, most of the doctors did ask. In fact, all of the doctors did ask, and we did know whether it was a first presentation. The patient was known with obstruction. So it's important to know if the patient is known with an obstruction, because that tells you that your success of inserting a Foley's catheter may be reduced. Patients known with obstructions, generally when their catheters come out, or if they've been on medication, for example, your Uramax and your your dilatory medications. Sometimes when we start giving, or your hyperplasia or malignancy gets worse, it becomes much harder to actually insert a catheter through that. So you need to have that in mind before you even start. So majority of these patients who are known with obstruction will end up with a case where you may get lucky, you place a catheter, it goes in, there's no problem. And you may also end up with a situation where you need to dilate that stricture or that blockage before you can get a catheter in. And in some cases, it's impossible to dilate, and the patient may need a suprapubic catheter. Okay, so you have to understand why that's happening. Okay, so like in our case, we had 5 patients who were known with obstruction, and only 1 had retention received by simple passage of a Foley's catheter. Okay, so that just shows you how. So that's 20%. So that in our very limited cohort, you could draw the conclusion that 80% required a dilation. So it was the Foley's catheter passed on the first attempt, and primary means for relieving obstruction. So in a younger patient, you would expect this to happen. In elderly patients, those with chronic obstructions, you wouldn't expect it to happen. Okay, so in our case, we only had 2 of our patients that were easily relieved. And once you have that relief, great. It goes in, everything comes out, the urine comes out, patient feels much better. And most of our patients, unfortunately in our setting, a lot of our patients come either after they've been symptomatic for quite some time, now very distended bladders, or chronic obstructions, and they've removed their catheters. There's a lot of things that cause it. And you need to know what to do if it fails. So there's a few things that you can do. So one of the main things that I always ask people to look at is bradycardia. Now, why is that so important? Number one, as your bladder fills, your patient will come in extremely restless. So you'll have this person who cannot sit still. He's in a lot of distress, in a lot of discomfort. He's just moving around. You can give them whatever sedatives you want, whatever it is, nothing's going to help. Right? And what will happen is that your patient will slowly but surely continue to distend the bladder. Now, as it distends, of course, this is an obstructive urology, so you start getting hydronephrosis. And in the acute stage, hydronephrosis, while painful, is not extremely dangerous. Over time, then of course, it leads to renal impairment and eventual chronic hydronephrosis and chronic renal impairment. But in the acute setting, which is what we are dealing with in the emergency department, the main thing that's important with the dilated bladder, because remember, you've got your bladder, you've got your rectum. On top of your rectum, you've got your bladder, you've got your rectum, and just there, you've got your major vessels and your vertebra that are also running just below that. And one of the main nerves that are running there that also supply your bladder is your vagus nerve. So your vagus nerve, now, for those of you who don't know the vagus nerve, I can read it, because your vagus nerve controls so much, from your diaphragm, to your SA node, to your bladder, to your intestine, do so many things, smooth muscle relaxation, smooth muscle contraction. There's so much that happens. But as your bladder distends and as it presses down on the vagus nerve, it causes irritation. So this is the equivalent, I would say, of how do I explain? Of giving the patient blocking drugs such as adenosine or doing a carotid rub or something to that extent. So you're causing direct irritation to the vagus nerve, which starts leading to bradycardia. And this is actually one of the danger signs. Now, why I say this is because if you don't look for bradycardia, you're not going to know how quickly you need to relieve this obstruction. If bradycardia is present, you may not even have time to really insert a Foley's catheter, or you may only have time to try once, and then you've got to try and relieve it. Okay, so what I would say is that this is something that you really need to look at, right? It has led to cardiac arrest, arrhythmias in patients, things like that. And the problem is that if you don't relieve the bladder urgently, you don't really have a medical legal defense. So you have to at least note it down. So it's quite easy to note it down. It's part of your vitals. But what I'm saying is, even though we don't tend to note our vitals, we may not necessarily take note of it. So if you have a patient, distended bladder, heart rate less than 60, relieve that bladder as quickly as possible. So how can we relieve it quickly? It's as simple as a needle aspiration of the bladder. So you may ask, okay, how do I do that? So it's quite simple. You take one of your larger IV cannulas, one of your larger gel packs, either an orange or black or green, so either 12, 14, 16, 18, even if you have to. And attach a 20 ml syringe onto that. And you basically go in the midline just above the pubic symphysis, and you insert it into the bladder. And you, of course, you operate as you're going down until you hit urine coming out. And then what you do is take an IV line, a normal IV line, and exactly how you would normally attach an IV line onto that, you just go and attach it on and let the bladder empty out into a bucket. That's all that you need to do. Let's say you don't have a bucket, even you don't even have an IV line, then you just empty it into a container with your 20 ml syringe, or keep the container underneath the IV cannula. So once you hit urine, you remove the needle and you remove the, you just pass the plastic cannula through. The reason being you don't want to go to the posterior part of the bladder, because at the bottom, even though the distension tends to happen more towards the superior pole and the lateral poles and not the inferior pole, so you want to make sure you don't go through the bladder as well. Okay, so in our case, we had 2 files where I could see the heart rate, and in both the cases it was only noted by the nursing staff. So it was quite a bit of a worry. It was something I said I need to point out to you guys as well. Right? So the bladder fullness also helps. It's because bladder fullness tells us if your patient can have a suprapubic catheter inserted or not. So if your bladder is empty, even though your patient may be unable to pass urine, of course, you're going to try first with the Foley's catheter. Failing a Foley's catheter, you may want to, and of course, you're going to note your bradycardia. If you need to aspirate to relieve, you no longer have what you call it, an area to insert a suprapubic catheter. So, you need to know what's your next step. So if your patient doesn't have a full bladder, then you need to have them admitted. They need to put an IV fluids. The reason being you need to build that bladder up so that your patient can eventually have a suprapubic catheter if all else fails. That's the main reason for noting that. So we only had one patient which noted, right? So what about dilatation of the suction catheter now? The suction catheters and the normal suction catheters that we use in resuscitations, that we use, for any sort of suction that we need to, right? And as you all know, they come in different sizes. So 18 French, 16 French, 20 French, all of that. So you basically just have to pick one of those. So what I would say is the easiest way to do it, especially with a situation like what we have, where you've now tried to, let's say, insert a size 14 or size 16 Foley's catheter. It's not passing. You can actually feel it hitting the stricture. It's just not going through. Take a suction catheter of the exact same size first, and you slowly insert. I understand it's a very painful process. The reason being, The suction catheter has oval openings towards the front that are meant to assist with suction. And these are actually quite painful as they pass through the urethra. So you can either, provide anesthesia or some sort of analgesia. You coat it in enough lubricant as you can, and then you start passing it through. And what you note is that because it's a more rigid structure, it's a more rigid catheter than the Foley's catheter, it will dilate a soft structure. So you'll be able to go through, and once you see urine coming out, you leave it there for about a minute, then remove it and try and insert the same size catheter again. Okay, Foley's catheter. Now let's say the larger one doesn't work. So you've tried the 16 or both, the suction 16 and a Foley 16, it doesn't work. Then I would go a bit smaller, with a 14 suction and a 12 suction. And then once you've got that particular size through, then insert that size of Foley's catheter in, or go even a little smaller, just so that you can pass through that stricture. Okay, so like I say, it's only to pass to be able to dilate a soft urethral stricture. It will not assist in a hard stricture or a chronic stricture. You won't be able to pass it through. Okay, so in 2 of our patients, they had this done. It was done very well. I saw the notes of the doctor who did it. Well, there were 2 separate doctors who did it, and they did it very well, very well. And like I said, there's nothing wrong with both these patients ended up getting suprapubic after, because they ended up having quite a few complications. That was a bit, it's more in those specific cases. I don't want to get too into it. Always remember, there's nothing wrong with inserting a suprapubic catheter. There's a higher rate of complications for these patients. Okay, so what about suprapubic catheter? Now, suprapubic catheter really is the last step. All right. So prior to this, you have your dilators that can be used by the urologist. Now, I'm not going to go into great detail with those because we don't have access to them. But if you work in a urology department, you'll find that you have access to your dilators. So for those of you who haven't seen them, they look like large hooks almost, with blunt ends and a nice big handle on the one side. And they come in the different sizes. So what happens is, because this is metal, it's able to open up a hard stricture as well. And it's a very uncomfortable process. I must be honest. You can see the patient suffering during it. But what happens is, it then opens everything up. It allows you to pass a Foley's catheter, and this is preferable to inserting a suprapubic catheter. So if you have a chance, I'm trying to get a hold of one of the videos, and I think one of the videos does detail it in how it's actually done. But it's not something you normally have access to in the emergency department. It's not part of the emergency department equipment list. So most emergency departments don't keep them. So if worse comes to worse, you can insert a suprapubic catheter, and I'm going to include a video on how you insert a suprapubic catheter. It's a very easy skill to have. Okay, and it's one of those things that once you know how to do it, it's quite easy. It's basically like inserting an IC drain or injury. You're just making a little hole and then accessing the bladder and inserting a tube inside. That's it. But it does require a bit of skill. It's not something you can just go ahead and do. Okay. So in our case, the urology team came and did it, but it's something that the A&E team should be able to do as well. So this is just our little algorithm that shows how we should go about it, which I'm going to provide as well. So you can have a look at it. It's not a very good picture here. Just trying. So yeah, it's not going to work on this. So there we go. So you can have a look at it here, but like I said, I will link to it as well. And so I hope you guys learned something as well. And if not, no problem. You can always, go back, look at the videos. So it's quite a bit to look through, but it's something that everybody needs to know if you work in any sort of emergency setting. Okay, thanks a lot. Keep well, and hopefully next week we'll have the next week. Okay, bye.